Okay, everyone. I'm Danielle Hassel. I'm the immediate past president of the Memphis Medical Society, and I'm elated to welcome all of you to our special presentation. This committee is a diversity, equity, and inclusion committee, a joint effort by the Memphis Medical Society as well as the Bluff City Medical Society. We realize that most of us have had a long day, and we just appreciate that you've taken the time to join us tonight. We'll move forward with the program. First, we'll have the purpose of our committee explained by Dr. Washington, who is the president of Bluff City.
Hi, good evening, everyone. So as Dr. Hassel stated, we are a combined diversity, equity, and inclusion committee with the Memphis Medical Society and the Bluff City Medical Society. We understand that we are in a very unique position in healthcare as healthcare providers. And with the pervasive nature of medical bias, it's very important that we address key issues as we work towards bringing health equity to light. So our purpose is to come to a place of understanding, and the way that we do that is by bringing knowledge. We have to acknowledge the history of our healthcare system and the history of marginalization of people groups so that we can move forward and achieve health equity for all. Thank you.
And next, if we could have the introduction of the speaker by Dr. Erica Dillard.
Good evening, everyone. My name is Dr. Erica Dillard. I'm a postdoc fellow here in Memphis and a member of Bluff City Medical Society. And it is my honor to introduce our esteemed speaker for this evening's event, Dr. Cozzette Lyone-Jones. Dr. Lyone-Jones hails from Buffalo, New York. After completing her bachelor's degree in science communication at Cornell University, she went on to obtain her medical degree from the State University of New York at Buffalo's College of Medicine. After making her move from the East to West Coast, she currently serves as Chief of Adult Medicine at Watts Healthcare Corporation in Los Angeles, which is a historic federally qualified health center birthed out of Watts' uprising of 1965. I came to know Dr. Lyone-Jones through her role as president of the Association of Black Women Physicians, or ABWP, which is a nonprofit organization established in 1982, focused on closing gaps in health disparities through community education, professional support of women physicians of color, and mentoring of future Black doctors. In June of 2018, Dr. Lyone-Jones completed the Executive Masters of Public Health program and is a recipient of the Angie Quilley Memorial Fellowship Endowment Award from UCLA Fielding College of Public Health in the Department of Health Policy and Management. This identifies her as an influencer impacting the public health landscape. She was also inducted into the Delta Omega National Honor Society of Public Health for outstanding academic achievement, devotion to public health principles, and an exceptional service in public health. As an advocate for improving global health care, Dr. Lyone-Jones has lobbied on Capitol Hill for global AIDS funding, graduate medical education funding, and opioid and chronic condition reimbursement policies through her affiliation with the American College of Physicians Advocacy Committee. She has led medical missionary teams to India, South Africa, and Rwanda, and she has also provided healthcare assistance to earthquake-ravaged Haiti in 2010 with the California NGO Giving Children Hope. Through these efforts, Dr. Lyone-Jones was invited by US Congressman Maxine Waters to present a status update on Haiti 5 years after the earthquake. Dr. Lyone-Jones understands what it truly means to be a healthcare advocate as a physician and a caregiver. As a caregiver for her mother, who was diagnosed with dementia at a young age, Dr. Lyone-Jones currently serves as a member of the advisory boards for the Women's Alzheimer's Movement, the Alzheimer's Association, California Southland Chapter, and is also a brain trust member to Governor Gary Newsom's California Alzheimer's Task Force. She is married to her college sweetheart, Noel, and is the mother of 2 beautiful children. She and her husband both co-host the radio show Uncontrolled Substance with Dr. Cozzette on the Real Urban Radio Network. On a personal note, she is a true role model, and for me has set a precedent for how to ensure actionable changes to achieve more diverse, equitable, and inclusive healthcare and medical education. So without further ado, I turn it over to our speaker, Dr. Cozzette Lyone-Jones.
Thank you, Erica. That was wonderful. Thank you. I'm overwhelmed. It's my privilege to be here on today. It's a heavy topic, I know, but it's a necessary conversation, and it helps to move the needle in terms of addressing the structural and systemic issues that are barriers to our getting to a healthier place as a nation. If you ignore one group or any group goes without, then the whole suffers. So the intent of the presentation on today is to bring to light some examples historically of the interface as far as the history of medical care and medical science in the African American community. Next slide, please. Antebellum medicine, basically between the 17th and the 19th centuries, we find ourselves being more, in a space of not having the scientific knowledge to support the decision-making process when approaching patient care. And the knowledge of pathogenesis of disease and the microbial basis of many diseases was not known. Couple that with the absence of anesthesia until the late 1830s and 1840s, and you find a common thread that I'm going to bring up over and over again throughout the presentation, as far as the pain that African Americans in particular and many marginalized groups were subjected to as far as experimentation and medical management. And it's important to keep those 2 points in mind. Well, when you think about the antebellum medicine period, there was marked differences between how medicine was being managed or performed over in Europe compared to Western medicine. Europe was ahead of the curve as far as public health institutions and practices being implemented, as far as the scientific medical education that was presented and the training over there, and the establishment of hospitals. But even if you come, within the continent, within our country, there was a difference between the South, the North, and the South, right? So most antebellum Blacks lived in the South, and so they were subjected to Southern medicine. African Americans arrived into the colonies around 1619, and that number increased to about 20,000 in the country by 1700. It rose to 5,500 by 1776. Now, by 1807, you have a situation where the importation of slaves is no longer allowed. So with that prohibition, you still see an increase in the numbers to 4 million enslaved Blacks by 1860. And this is the equivalent of about $4 billion in today's economy. So when you think about it, how were they able to do that if we weren't able to legally import? And this was done through breeding of those who were already here in the country. Northern medicine also was at odds with Southern medicine in terms of the training, and the institutions were fighting against each other because those who were in the South felt they knew Blacks better than those in the North because more Blacks were in the South, right? And so we know our slaves, we know our Blacks. You see this coming to a head right at the Civil War. On the eve of the Civil War, actually there was rallies where a vote was taken for casting a vote, yay or nay, as to whether or not there would be this mass exodus of students who were from the South but were attending school in the North. And what you saw was in one instance at Jefferson College, there was about 200 Southern students who actually did disenroll from that college, and then 100 more of them disenrolling from the University of Pennsylvania. And this was somewhere around 1859, 1860. And so there's a lot of divisiveness, even in the practice of medicine between the North and the South. Physicians were dependent upon slavery for economic security, for the use of Black bodies, for medical research, for medical training. Slave owners and physicians, they shared a common interest in preserving the slaves' health and the institution of slavery. So that is the seed in terms of the antagonism between Black patients and the medical system and physicians in particular. And it started right there at the inception of our country within the context of the institution of slavery. The doctor-patient relationship, when we talk about that today, the voice of the patient, is what we talk about. That's, front and center. That's everything. You have the PAT-SATs that, many of our bonuses and some of our medical groups ride on, your performance and how well you do on your patient satisfaction scores. So the voice of the patient is not the same, when you put it back in antebellum medicine context, because the voice of the owner actually was prioritized over the voice of the patient. And then there was issues between Western healers and African healers. Western practitioners tend to look down on African healers. They view them as superstitious. And African healing philosophies, they included psychological and social and spiritual components, but in spite of that, and even knowledge of roots and herbs and all that, and they've had just as much educational time and time spent in study at that time as compared to their white counterparts, but still there was issues there. Africans, for example, first used citrus juice for scurvy and inoculation for smallpox and other viral diseases. You had white women who called for African midwives to attend to births because their techniques avoided the use of the forceps. And as we'll talk about more later on when we talk about Dr. Marion Sims, the forceps resulted in a lot of complications, post-operatively, postpartum for these women, and poor outcomes in terms of delivery of these fetuses. So they called on the midwives because they tend to have better outcomes comparatively speaking. So there's a lot to unpack there. When I think about the owners, they restricted medical care for the slaves in many ways. They believed, like I said before, that they best understood Blacks. The owners determined how to ration, medical care. They didn't call for the physician right away. It was usually when the slave was in extremis is when they would call on the physician. Before that, they would use all kinds of cocktails and drinks and caustic substances to motivate the slave to get up and get back in the field. So they did that to save money, basically. What was common back then was to accuse slaves of malingering. And they would call on the physician to confirm that. But again, the physician had to balance, their money is coming from the slave owner, not so much the satisfaction of the patient that they were taking care of. And so they were kind of caught in between a situation. And for slaves who were accused of malingering, oftentimes they were whipped as the medicine for that diagnosis. Physicians were used to verify the fitness of the slave. They would, in the medical records, if you go back and look at historic documents, it would document the poor living conditions of slaves, and the medical records was well known. They would document that the slaves were overworked, they were undernourished. All of that was found among the physician documents, and that's good, as far as actually documenting what they were observing, and not being jaded by the institution and by the slave owner. However, at the end of the day, they sided with the owners for economic and political reasons. So that was still there. And yet also, when you contextualize antebellum medicine, you have to think about it was being practiced within the context of scientific racism. The practice of using race to make biological differences coincided with the takeoff of the slave trade. So it was economically beneficial to make these distinctions in terms of justifying enslaving humans. If you think about the taxonomist, Carolus Linnaeus, he categorized African Americans and Blacks by extension as Homo afer. And then there was a theory that was held that Black men had different evolutionary starting points, had evolved along a separate evolutionary track from white men. And this was, for all, groups, ethnic groups. If you talk about Native Americans, Asians, it was the same situation. Physical differences between Blacks and whites was made into a hierarchy of humanity. And so if you saw a term in a textbook that said different from whites, that usually meant inferior. And these Black flaws were documented in medical journals and in textbooks, and it was used in the treatment of Blacks. Physicians of the times, they believed that Blacks had low intellectual capacities, that they were sexually promiscuous, that disease manifested differently in Blacks. Blacks were not likely to take their medication, that they would be not compliant with treatment plans, that Blacks naturally harbored disease. And these beliefs were used to rationalize the abuses that took place against the enslaved Black men and women. This gave birth to iatrophobia, or fear of medical care. And this is something that we see to this very day. Currently, the struggle that is real in terms of having conversations about public health initiatives like accepting a vaccine, even before the pandemic. If you think about the flu shot, how many of you have struggled with trying to get your patient to take a flu shot? That's before COVID came along. So slaves, in addition to being accused of malingering, on the other end of the spectrum, was also at times accused by the slave owners of hiding their illnesses. And there's some truth to that because of the fact that slave owners oftentimes, made it punitive for you to even speak up and say that you didn't feel well, because the objective was to get you back into the field, right? So that is something that sowed those seeds of distrust among slaves towards Western remedies. And the fact that the slaves would notice that they would use the same medication for 20 different ailments, right? And they're looking at this and like, I don't know. So different philosophies, no spiritual components like with the African healers, all of these things came into play when it came to the development of iatrophobia in the Black man. So there was a fear and a loathing of Blacks toward the healthcare system in America from the beginning. Next slide. So in 1851, this gentleman in this photograph, this picture is Dr. Samuel A. Cartwright. He was in Louisiana, and in 1851, he coined this term, drapetomania, and it means runaway slave syndrome, basically. So it was created to pathologize the desire of men who were in bondage and wanted to be free and tried to escape. And instead of looking at that as a normal response, as Dr. Cartwright, he looked at historically, say, enslaved people in ancient Greece or Rome, and he thought it was a normal response that they wanted to be free. But when he looked at the Black man, he didn't have that same response. He labeled it as a psychiatric disorder. And this Greek word means flight and insanity. And so he pathologized this, and this disease, quote unquote disease, was treated with amputation of the extremities. Next slide. But there's nothing new under the sun. If you fast forward to the Reconstruction era, you find that white American doctors argued that former slaves would not thrive in a free society because their minds couldn't cope psychologically with freedom. In the Civil Rights era, psychiatrists used the concept of schizophrenia to label Black activists as violent or hostile or paranoid because they threaten the racist status quo. And if you go and kind of read in the literature back then in terms of what was going on in the area of psychology, the DSM manual, the Diagnostic and Statistical Manual, the second version actually changed the language when it went into that section about schizophrenia. Initially, schizophrenia was something that you saw or associated with housewives who were non-threatening. But as we got to the civil rights era of the 60s, it shifted. The language and the perception shifted from the non-threatening housewife to the violent, masculine, paranoid person, and it was racialized, and it was convenient. There was a method to the madness, so to speak. Next slide. But no conversation would be complete without mentioning the father of gynecology, Dr. J. Marion Sims. And this is from the Time article. I don't know, I remember when this came out. It was fascinating to me back then in 2017 when they removed his statue from Central Park in New York City. The controversy wasn't so much about the merits of his medical achievements, but how he accomplished them. He founded New York City's first women's hospital, and he innovated all these surgical, techniques, as we'll talk about in a little bit more detail in a moment. But his success came at the cost of unethical medical treatment of enslaved women in the antebellum era. Next slide. Going deeper into the rabbit hole of obstetrics practice and Dr. Marion Sims. When we think about Dr. Sims, there's a name that always comes to mind for me that I want to leave with you, and hopefully you'll remember this name, because there's so many faceless, nameless people who suffered, through the ages. But I want to put a name to this particular person, and the woman portrayed in this image is Anarcha. She, in 1845, was 17 years old, pregnant, was in labor, and she had a prolonged labor of 3 days. Can you imagine? I had one child, and 12 hours was enough for me, but for her, it was 3 long days of labor. And they called in Dr. Sims to come and support her through that. And he used the obstetrics forceps and tore the vaginal area, created fistulas to the bladder, rectal areas. And this young lady had to deal with incontinence and pain and infections and odor as a result of that. At the time, there was high rates of vesico-vaginal fistulas among slaves with the onset of the use of the forceps. And Sims, he practiced a lot, beyond, that use of forceps in delivery. He honed his skills and developed his techniques on the bodies of Black women who were without anesthesia, who did not give informed consent. The IRB was not in existence back then, right? And there were times where one, slave would hold her down, like your mom could be called in to hold you down, or your girlfriend could be called in to hold you down against your will, so that he could do what he was doing. He experimented on a total of 11 slaves over a 4-year period, and over 30 times on Anarcha herself. So it's incredible to think about that. It's painful to think about that mentally. Again, he didn't give anesthesia, but let's think about this. Anesthesia was actually around at this point, came into use around the late 1830s, early 1840s. And so at this point, when he was performing these experiments, he did have access to anesthesia and chose not to use it. And it was because of the common belief that still lingers now, and we'll talk about that towards the end of the discussion today, that Blacks have thicker skin and that their pain receptors, were different. So they didn't have the same level of pain as other groups, and their pain thresholds were higher. So he didn't give anesthesia, but he gave post-op morphine to these women. So he kept giving them hits and kept giving them the morphine afterwards. And you're thinking, okay, that's kind of, contradictory to what he's saying, preoperatively. But it is thought that he did this to keep them subjected to this, that they would continue to be compliant, continue to participate in these procedures, some of them becoming addicts, some of them in such a stupor that they were just too high to get up and to leave or to, scream and protest. Dr. Sims' work was published in the American Journal of Medical Science in 1852. Next slide. When we think about medical education, I can remember my cadaver years. I don't know about you all. I have some stories about my anatomy class and all that. But when you think about it in retrospect and contextualizing it to what we're talking about today, now I have questions about my education and the things that I experienced and things that I heard. And I know that I experienced, and we could talk about that later if anyone is interested and if we have that kind of time. But medical schools solicited for slave owners to actually send them patients. And schools were establishing hospitals for Blacks and for low-income patients. So slaves who were too old or too sick, or they no longer were seemed productive to the owner, were the ones that were sent to the hospitals. The owners could get some money. Well, I can't get anything else out of you in the field. I may as well get $1 off of you and send you over to the hospital and let them do whatever they're going to do, right? The hospitals were physician-centered. They were physician-owned. So many of these vulnerable patients perceived that it was more so a place to go and be experimented on and to die when they were sent to the hospital. That is the relationship that Blacks had with hospitals. And I will tell you this, and I'm in Watts, where I'm practicing. And many of my African-American patients to this day feel the same way. And if you wonder why some patients wait and they present late in their disease courses, they may have some form of cancer or some other disease that progresses over time, and they wait until they can't wait anymore. It becomes too painful, it's too large, it's whatever, and then they finally present to the doctor's office. You can go back to this time, during slavery times, when the hospital was viewed as a place to go and die. That concept, that perception is still there for many people of color, because of the contentious relationship that we have with the medical community and with the scientific community overall. There were newspaper ads asking for free, for people, to come, and these ads would be for free care of the sick and aged slaves. So they would promote this. And what I would want you to the fact that this would be in a newspaper or in a magazine as an advertisement, it boggles the mind for me. When I think about this one example that I have on the slide at Atlanta Medical College in 1856, they attracted students through newspaper ads, promoting this case of the hepatic abscess in a Negro man. It's kind of like a circus, right? Come on, come on, right? We got this, over here. But for this particular case, they lectured on this person, untreated, as an example in front of the students for weeks and weeks. And then there was a woman with TB who they kept under observation for students to learn over a 1-year span. Incredible. And this is not uncommon. You'll see this when we talk about Tuskegee later on, which was over 40 years of observing the natural course of a disease, of something that we already knew the natural course about and already had treatment for. So there were mostly Black bodies that were put on display in medical journals because it wasn't acceptable to have white bodies put on display at that time. The objectives of the medical school was to promote medical education. It wasn't to give good care, culturally competent, compassionate care, you know, like we talk about today. It was about the student and attracting talent and the numbers and vying for that. So it was a plus for the school to have a large supply of low-income patients for students and residents to practice on, right? The Medical College of Virginia, for example, established a hospital solely for Blacks and ensured that the supply of patients to, you know, train the medical students, you know, was being fed there. The concept of the time was that, okay, we give you this free care, what are you going to give us in return? We know you don't have money, you don't have property, you know, you don't have anything, you know, tangible to give us, but you got your body, right? Participate in this study, you know. So that was pretty common. It was expected that Blacks would willingly become research subjects as payment for having been treated in these charity hospitals. In 1989, if you fast forward and you think about the fact that there were these resurrection men, you know, who would rob graves of bodies. You know, someone, you know, dies, they get buried. You get the 911 on that. You know, the med school finds out, tells the resurrection man in the middle of the night, he goes in. Oftentimes the resurrection man was a Black man, and he would go dig up that body and deliver that body back to the medical school. That's how they got bodies. It was not uncommon. Some people just went missing at times, and it was legal for those bodies or persons who died who were John Does or Jane Does who had no family to claim them to be, you know, sent to medical schools or to sent to research, you know, labs for use, you know, in those areas. That was not uncommon. So in 1989, if you fast forward, construction workers doing their thing at the Medical College of Georgia. Oh, what do we have here? Whole bunch of Black bodies buried under the school. Can you imagine? How disrespectful, even in death, right? Next slide. We can stay right here. So think about this. Fannie Lou Hamer, because I'm giving you flashpoints in history because we can't do it all, right? I'm going to take you in the past, bring it forward, connect the dots so that you can kind of see why we feel some kind of way in the Black community when you approach me with a vaccine that seems to me to have been fast-tracked, right? You know, everything was under fast experiment. You're not experimenting on me. You know, you did enough of that, you know, back then. I'm giving you, you know, some of the history, the context, so that you can understand why some people feel some kind of way, you know, when it comes to science and the medical community. So Fannie Lou Hamer at the age of 19 was subjected to what is called a Mississippi appendectomy, which is a sterilization without consent. This was common in the South. A Black woman will go in for one type of procedure and she'll come out sterilized and wouldn't know it. And that is actually what happened to her. And that was the thing that ignited or lit her up, you know, made her woke, I guess, and led her to becoming this voting rights activist. Next slide. And then when we talk about the vulnerable, we think about children, we think about the elderly, we think about marginalized communities. I also think about the prisons and those who are incarcerated. And because mass incarceration is, you know, it's economically beneficial to our country to have that. So there's something to it. It's not just about putting away the bad guy. There's something to having this institution in America. I wanted to cover Dr. Kligman, a dermatologist, a famous dermatologist, and talk about his work at the Holmesburg prison, and then kind of touch a little bit on 3 other points in history in which research was done on inmates. Next slide. But with Dr. Kligman in particular, he was a dermatologist, and he's famous for a lot of things. He described the human hair cycle. He talked about acne, the natural course of acne. He coined terms like photoaging. He discovered tretinoin, retin-A component, and revolutionized, acne and management of wrinkles and all that. And he donated millions of dollars to the University of Pennsylvania's dermatology department. Next slide. But it was interesting when he walked into the Holmesburg prison, he was quoted as saying, and you can advance to the next slide, he was quoted as saying, "All I saw before me were acres of skin." He didn't see people. He didn't see humans. He didn't even see bodies. He saw skin. I thought that was pretty deep, but it sums up pretty much his mentality and how he was able to do what he did. He directed experiments on about 75% of the inmates of that prison. It's located in Philadelphia area, and this was between 1951 and 1974. Each prisoner who participated for each experiment that they participated in got between $10 and $700. And you can be in multiple experiments or research projects at a time. You didn't have to do one at a time. It was just confounding. It was just messy research all the way around. A no informed consent, disaggregation by race, that who cares about all that, that just went out the window with this. He tested different substances. He looked at the odorants and shampoos, radioactive material, hallucinogenic and toxic materials. He tested about 153 experimental drugs over a 4-year span between 1962 and 1966. This part is really deep when I came across this. Over 30 pharmaceutical companies and several government agencies knew about this, sponsored it, participated. Prisoners were deliberately exposed to herpes, to warts, to staph, to gonorrhea, to syphilis, amoebic dysentery. And this is documented in a book called Acres of Skin by Alan M. Hornblum, if you're interested in reading that. Next slide. Oh no, stay on this slide for a second. Why can't you go back to the previous? Yeah, stay right there. Thank you. These slaves were, not slaves, sorry, these prisoners were enrolled in multiple studies simultaneously. And there was no informed consent, like I mentioned, and poor record keeping. Fast forward to October of 2000, because I'm connecting things that were done in the 1800s to modern times. This is in our eras, when we were adults even, right? In 2000. Nearly 300 former inmates attempted to sue the University of Pennsylvania, Dr. Kligman, Johnson & Johnson, because they were the main marketeers of the retin-A, and others. But unfortunately, the suit was dismissed because it was beyond the statutes of limitation. The federal regulations were enacted in 1978 as a result of what happened there in huge part at that prison. It was 3 years after Holmesburg was closed for business, but it was the thing that ignited, the conversation and led to federal regulations against doing that ever again. Next slide. There are other stories of inmates and medical research, and Sloan Kettering Institute in Ohio State Prison is one. In 1952, the NIH sponsored a study there in which Chester Southern, he injected almost 400 inmates with cancer cells, human cancer cells. At Tulane University, there was a psychiatrist, Dr. Robert Heath, who in the 1950s did psychiatric research, and his partner that worked with him, Dr. Harry Bailey, he referred to the subjects as niggers. So that lets you know right there was no respect for the subjects that were enrolled in these studies. And they did brain stimulating implants and CIA funded drug experiments using hallucinogens, LSD and all that, and put these subjects into catatonic states and stupors. In Alabama, there were 3 different prisons in the 1960s that actually carried on blood plasma trials. And in those studies, up to 28% of the subjects developed hepatitis. Next slide. Now, we often say the Tuskegee experiment, but I like to say the entire title, what it really was called. The study was called the Tuskegee Study of Untreated Syphilis in the Negro Male. I like to say the whole thing so that you can get a sense of what the agenda was. It was untreated. It wasn't untreated because there was no treatment available, because penicillin existed at that point and other people were being treated. They weren't untreated because they were given informed consent and told that they had options to opt in and out of treatment. They didn't know that there was treatment that existed. So between 1932 and 1972, you have the Public Health Service that tracked about 600 low-income African-American men in Tuskegee, Alabama, about 400 of whom developed syphilis. The stated purpose was to better understand the natural course of the disease. To do so, the men were lied to about the study and provided these sham treatments. Many of them needlessly passed on disease to family members, suffered and died. There was one scholar who said that the Tuskegee study revealed more about the pathology of racism than it did about the pathology of syphilis. In fact, the natural course of syphilis, like I said, was already known. You know, it was largely understood. This study was publicized in 1972 and immediately halted, outrage, when the public found out. To this day, though, it is frequently cited as a driver of documented distrust in the health system by African Americans. That distrust has helped compromise many public health efforts. If you think about it, the slowing of the spread of HIV among the African American community, containing tuberculosis outbreaks, the current pandemic that we're in. These are examples of how this is still something that we're feeling the effects and the impact of. That distrust has compromised public health and our relationships with our patients even. There were economists who actually studied the Tuskegee study of untreated syphilis in the Negro male. And according to their work, Black men were thought to be less likely than white men to seek health care and more likely to die at younger ages as a result of this study. Their analysis suggested that a third of the Black-white gap in male life expectancy in the immediate aftermath of the study could be attributed to the legacy of distrust that was connected to the Tuskegee study. Their study relied on interpreting observational data, not a randomized trial. So there is room for skepticism about the specific findings and interpretation, but nevertheless, their findings are consistent with a lot of the other works that have been since published. That distrust of the healthcare system by African Americans, the receipt of less care and their worse outcomes can be directly correlated to this study happening. So when people try to say, oh, there we go again, you know, because, you know, everybody, when they say, why don't you trust me? People say Tuskegee, and like, oh, is that the only, they act like it's the only thing that has happened historically. But think about it, this went on for 40 years. 40 years. Next slide. More subtle racism in modern healthcare. You know, we can talk about that, but I want to kind of take a pivot for a moment from talking about the perspective of the patient historically and talk about the clinician, the physician. As a Black woman, I have experienced, you know, a number of things throughout my career in terms of racism, from people making fun of my name. My name is French, it's Cozzette, like Les Miserables, the main character in Victor Hugo's book, right? But I remember there was a time when I was, you know, caring for middle-aged white female in a suburban clinic that I was working in here in California. And she looked up at the certificates on my exam room wall, and my name was on, you know, on the certificate, and she goes, Cozzette, you Black people have such interesting names. And I kind of chuckled and I said, well, actually, that's French. It's not a Black name, you know. I kind of giggled and tried to ignore her. But little subtle things, microaggressions, you know, that happen throughout our careers is what we have to contend with from the beginning, from the moment you say you're going to be a doctor as an African American, you have to deal with things on both sides. You know, trying to convince your people to trust you now that you're a part of a system that they don't trust, while trying to fit in a system that doesn't always want you. It's a balancing act. And I came to know my colleague that's here, you know, my peer, my sister, Erica, through common work that we're doing in terms of advocacy work. We came together because of outrage over the passing of Dr. Susan Moore. And so for me, when I think about the subtle things that can happen, I think about historically, hey, let's talk about the AMA for a minute, right? The AMA had to apologize to Black doctors. This happened after over 100 years of the AMA actively reinforcing, actively or passively accepting racial inequalities and the exclusion of African American physicians, you know. I applaud Dr. Ronald Davis. He was the immediate past president of the AMA at the time. He came to the NMA's convention in Atlanta, Georgia. This was in July of 2008 to apologize on behalf of the AMA for over 100 years of racism and racist activity against Black physicians. I know that was pretty heavy. He not only apologized to those physicians, but to their families and to the patients that they cared for, because it was the service that was bigger than the people that were in that room. It was the generations, you know, decades of Black doctors, their families who had to hear their cries when they would come home, being disturbed about how they were being treated, just trying to be healers and being a part of the healing community. To the patients, you know, who may have lost out because of the large number of Black people who decided not to go into medicine, you know, to say, hey, you know, you can have that, right? As a result of the racism that was directly projected at them. Next slide. So there are more subtle racism examples in modern healthcare. Let's think about chronic kidney disease. You know, we see it every day. I'm a internal medicine physician, primary care doctor. Diabetes is, you know, in the water, right? You know, you see that all day, every day. And high blood pressure and chronic kidney disease associated with those two conditions. And oftentimes, kidney failure, the incidence is higher, you know, among African Americans compared to whites. But you have fewer Blacks receiving transplants in terms of kidney donations. And you see them on the waiting list for longer periods of time, you know, comparatively speaking. Let's look at this study in the emergency room. They looked at some emergency room records in this one study and looked at the waiting time and the triaging of African Americans compared to non-Black patients. And it noted that Black patients were more likely than whites to receive lower triage scores for the same complaints. Triage personnel rates were lower for the same condition. So we both can come in with a fracture, right? And I could say a 10 and a non-Black person could say a 10. My 10 would be downrated. Oh, they're exaggerating. Right? Because remember, my skin's thicker, you know, remember my skin's thicker, my pain threshold is different, you know, I don't feel pain. So she has to be exaggerating, right? So when you triage someone with a lower score, that translates into longer waiting time. So when you think about when time is critical, conditions like strokes and MIs, when someone comes in and you have a cold Amy, or someone that needs quick intervention and time is brain, right? And you're down rating the scores, that translates into poorer outcomes, right? So there are several studies that have shown that physicians spend less time with Black patients compared to whites and are less likely to perceive the patients as being honest regarding their symptoms. Let's take a famous example, Serena Williams. When she was having her baby, she, after delivering her child, was having symptoms. She felt short of breath, and they were familiar symptoms to her because she had been diagnosed with pulmonary embolism previously. And she knew, you know, how you diagnose it and how you treat it and what the symptoms feel like. So, and she's an athlete. She knew her body, right? Athletes know their body better than most, you know, because that's their money, right? And so she started having symptoms that were similar to her previous event, and she brought it to the attention of her doctors. And they said she was being anxious. I think they gave us Ativan even. They, you know, anxiety, you know, you're exaggerating, overreacting, you know, you just had a baby, you're just, you know, all the hormones are hitting you. I don't know. they gaslighted her basically. And eventually they did listen, she did get diagnosed. I think at first though, they said, we'll get leg Dopplers. They did an ultrasound for lower extremities to check for DVT. And she was like, no, I need a CT angiogram. I mean, she was, you know, educated and had an experience in this, you know, and interacting with the medical community. She specifically knew, I need IV heparin, I need a CT angiogram. She's giving them, you know, so intelligent, you know, woman, you know, giving her the information. They did a Doppler and it was negative. Eventually, when they did the CT angiogram, it did come back positive. And so, you know, she was vindicated, but it could have been at a price. Let's think about someone who may not have had her celebrity or her means, you know, of being able to advocate, you know, to feel empowered to advocate for yourself and to be heard. There are many people who are not in that position. Yeah. So for me, that lets us know It doesn't matter about your money, your income, your level of education. You could be a physician like Dr. Susan Moore and know exactly, what the condition is, how to diagnose it, how to treat it, what the prognosis is if you are delayed in your treatment. It doesn't matter. It didn't matter that she said, I'm a physician and this was one of her own. They should have been able to talk shop, right? They didn't have to dumb it down or anything, they could talk to her in her language. They spoke the same language. They both went to medical school, right? Had training. And yet she didn't have that experience and had an untimely death as a result of culturally incompetent care. And that hurts. We're all at risk and it doesn't matter. So when we think about these subtle examples, let's go to the next slide. Talk a little bit more about some other things. We talk about healthcare disparities. African-American patients tend to receive lower quality health services, including for cancer management, HIV care, prenatal care. We know we have the highest infant and maternal mortality and morbidity in the country, and even worse than some third world countries, right? And that's even correcting for education and socioeconomic status, doesn't matter. We're less likely to receive treatment for cardiovascular disease and are more likely to get unnecessary amputation of the limbs. Black Americans with mental health oftentimes are subjected to being prescribed the older, more toxic or more cumbersome medications that have more worrisome side effects compared to the newer agents that are better tolerated. Studies have found that Black Americans are consistently undertreated for pain relative to white patients. And we talked about that quite a bit already. When we talk about health equity, you can go to the next slide. We talk about health equity and health disparities. I wanted to leave you with a quote in the New York Times article. Remember Evelyn Hammonds, God bless her, in the 1619 Project. She told the Times that there has never been any period in American history where the health of Blacks was equal to that of whites. Disparity is built into the system. Next slide. And so this is the DE&I committee, right? So I wanted to end with talking about some points to take home, from this brief, journey through our history. Health equity itself is the awareness of the conditions for optimal health for all people. Healthy People 2020 said it's the attainment of optimal health for all people. Health disparities, it's an outcome that is eliminated when health equity is achieved. So it's not about equal distribution of resources. It's about equitable distribution of those resources to the most needy, to those who are the sickest. And it doesn't throw shade on other populations if you give more attention to the population that is in greater need. Because if you're talking about the health of the entire nation and the lost resources in terms of people able to work without disabilities, people able to contribute, to society, it's important for us to look at it from the big picture perspective of being, in it to win it, with all people, no matter what color, what race, what socioeconomic status. But I love my girl, Dr. Kamara P. Jones. I'm a groupie of Dr. Jones. In fact, she's an honoree of ABWP's Lifetime Achievement Award this year in October. And she's a past president of the APHA. I love her because she, with a smile, will give you our history. With a smile, will give you Yeah, I'm a groupie. I saw somebody said she's a groupie for her too. Yes, she's awesome. But what I love about her is that she does something that I do. Like when I was installed as president for ABWP, I gave my story because I wanted people to understand the platform that I chose for the organization stemmed from my story as a Black woman in medicine and as a Black woman in America. And our platform is racism as a public health crisis. To address that, we need to make sure that we attack the things that could be barriers to achieving health equity. The things that are barriers are making it so that we don't want to talk about our history. I grew up not knowing any of this stuff that we just talked about today, right? I don't know how many of you were exposed to this, unless you were in a household where you were conscious. You know, if you were in that kind of household where you had the books and you had educated, parents, and they had access to information to be able to share with you, God bless you. But many of us didn't have that. And so we heard about Christopher Columbus, right? we heard about the Nina, the Pinta, and the Santa Maria. We heard about all those things, right? But we didn't hear about, really the brutality of slavery and the repercussions of it. We now know that toxic stress is something that's generational, that even though I wasn't there, I wasn't a slave myself, I'm still feeling the stress of that because of the systems and structures that were built on that institution, right? So when we disassociate ourselves from our history, we become a historical culture. And it makes it difficult and challenging because people take it personally if you try to bring this conversation to them, but it's not about you. It's not about the individual. It's about the society as a whole. It's about systems and structures that need to be dismantled. And if you disassociate from our history, then you can't contextualize how we got to where we are. So it's important to eliminate that barrier. Having a narrow focus on the individual is another issue that we have here. We are fiercely independent here in America, right? That's why we're having all these issues with mask wearing. It's my right, to choose. We don't think about the person next to, we don't think about it, trying to achieve herd immunity, because that's a concept that takes you away from self and connects you to humanity and to society. And we are fiercely independent, as Americans. And there's good things about that, but there's a lot of negatives to that. The reason why I'm bringing that up is because it takes the focus away from the real problem, which are the systems and the structures that bolster racial inequities that we see. The myth of meritocracy is another issue. And you can go to the next slide, and that's my last slide, it's my next one. In America, the concept is, anybody can make it. You work hard, you put in your time, you can make it. You can be rich, you can, get the education that you want and get that position that you want if you just put in the hard work. But it's not an even playing field, right? So that's a myth. The myth of meritocracy is what makes it difficult and challenging for us to have these kinds of conversations about getting to racial equity in America, because we're still believing that myth. So we have to change the opportunity structure, is what my girl, Dr. Jones said, and acknowledge that there is systemic racism, there's structural issues, and we have to not only acknowledge it, but understand that they're modifiable. The lazy man's way is to say, this is how it's always been done, right? Why change it, or we can't change it. This is how we do it. This is the way it's been. And so you feel like you're powerless because this is how it has always been. But these systems and structures are modifiable. They are. We have to transform consumers to citizens. Even within healthcare, you know, you're vying for, you know, the dollars, you know, you're trying to make that money too, you know. You make money in healthcare. We're not doing this altruistically for free, right? And so when we think about it, oftentimes the stakeholders at the table that's dictating everything, they stand to profit from keeping the system the way it is. You look at pharma, you look at the insurance companies, you look at all the different stakeholders at the table. We're not even talking about the patient, right? Talking about everything but the patient. So we need to address that. And we need to break down barriers to opportunities. So until we get the person to the table that needs to be at the table, because whoever you are servicing, if you are providing a service to a population of Latinx and Filipino and African-American patients, then the people at the table on your board and in your leadership and on staff should reflect the people that you're serving, right? The decision makers in particular should be constituted of these, you know, different groups that are being served. If you're in a company or an organization that isn't reflecting that, until you get there, you speak up on behalf of that group, right? That's the challenge, that's the charge. When you look and you say, are we where we need to be, you know, as an organization, as a company, as a medical group, wherever you are. And you look around the table and everybody looks the same. And everybody looks different than the people that you're actually servicing, then there's a problem. And there's opportunity though, in that situation. So you want to eliminate the barriers to health equity. You want to know the history of your nation. You want to challenge the narrow focus on the individual so that no one takes it personally and sees it as a societal concern that needs to be remedied. You want to deal with the myths that are out there, and you want to look beyond our borders and learn best practices. We think that America has all the answers, you know, and nobody else has answers, but there's a whole world beyond our borders that we can go and find best practices and bring it back home. So I'll close there and open the floor for any questions, because I might have even gone over, I'm not sure. I didn't pay attention to time, I kind of get lost.
Thank you